Hey, Irma, or Dr. Singarella. Oh, I think you're still on mute.
I mean, I should have known by now. It always happens.
I still forget. So, I mean, it's also like late in the day, and I just had my graduate class is on Tuesdays, and it ends at 5:30. Hey, Melody.
Where on Facebook is this streaming? Sorry.
This is on the Marcus Orr Center for the Humanities page. So just MOCH.
Thank you.
Commissioner Sawyer, I put the web page in the chat. It's facebook.com/UMMOCH. But yeah, it is live streaming. Yay.
Thank you.
Okay, Beverly, what did we do? What did you want to do to kind of?
So, sorry, I was just waiting for Dr. Foster to
Yes,
sign back in.
I'm almost there. I just typed my email in. Okay, and then it's saying that I can join. I guess someone can let me in. Is that what it's waiting for? Oh, I see me.
Oh, there you are.
Yes.
Yeah.
Okay, so we've got all our audio and video. We're live on Facebook and we are live on Zoom. That's great. So I guess we'll have people, we'll continue to arrive and we'll get started in a couple minutes.
I have a
Dr.
question.
Oh, yeah, go ahead, Dr. Foster. Did you also want to practice the share screen too?
You read my mind. I was trying to figure this out. Okay, so I have my files on a USB with PowerPoint.
So when you pull up the PowerPoint on your laptop, then you'll click share screen in the green at the bottom.
Okay. Let me do it this way. Let me go to here. PowerPoint. Okay.
Welcome, welcome everyone. Thank you for coming. We'll get started in a couple minutes.
Sure, I have the right one.
It's just so nice. Everybody's gotten so quiet. I'm accustomed to noise, like with students. And it is great to see everybody. Although I'll be glad to see people actually physically in a presence walking past me on campus. That would be good. Hello, Dr. Ford.
Yeah, I see a couple of people saying howdy and great to see everyone in the chat. Thank you. Thank you for that.
Hello, Dr. Sherman. a familiar face in the history department that we haven't seen in quite a while.
Hi, Jan.
This is the old teacher in me. Silence and quietness makes me nervous.
I think
Noise, movement.
Dr. Foster, I think, has is going to be pulling her slides up in just a minute to for us to just make sure we've got all the logistics here.
Make sure I have the,
And there's still people getting in, and I've had a few email messages about getting in. Zoom is always a little bit of a problem for logging in, so we'll wait a couple more minutes. And if you are on Facebook, this is being shared on the Marcus Orr Center for the Humanities page. So you could also share it out with friends. That's another way for people to access it. So I will drop that page into the chat. There we go. Should we get started speaking? Because we can always, try out the slides. Don't we have, I feel like we've got a fair amount of talking to do before any slides happen.
Yeah.
I did, I just forgot what I named it the second time. I'm so sorry.
Yeah, so Dr. Foster, feel free to, you could just pop in with your slides as we go. Our intro, I don't have a PowerPoint. Beverly, I don't think you don't have a PowerPoint, so we could just start with some of the formalities and then, work on the presentations as we get to it. So welcome to this panel on systemic racism and COVID in Memphis. I'm Melanie Conroy, the interim director of the Marcus Orr Center for the Humanities at the University of Memphis. So this event is sponsored by the Marcus Orr Center for the Humanities, also the Benjamin Hooks Institute for Social Change, the Department of Communication and Film, the Department of History, and the Health Spaces and Technology Research Community, which is a research community on our campus. Welcome to all of our guests from across the university. I know that we have people from many different departments here, and also from the Memphis community, including students and faculty from Health Sciences, the Black Students Association, and others who did a lot of important promotional work for this event. With that, I'll turn it over to our moderators for introductions.
Thank you so much, Melanie. Dr. Bond, did you want to introduce yourself first?
Okay, I will. I'll go ahead. You just threw me off. I thought we were doing in the other way, but
oh, sorry, or I could go first.
Now that I put my paper right here, we'll go ahead. Okay, good evening. It's good to see so many people, a lot of friends. We're not only from across the university and across Memphis, but we're also from around the United States, because we have someone from all the way up in that little spot off the coast of the United States called Maine, Vinyl Haven, Maine, who is joining us. So we're very glad to have all of you with us. I'm Dr. Beverly Bond. I'm a professor of history and of African American history at the Department of History. My courses focus on 19th century African Americans, on African American women's history, and on Black Memphis. I teach a course called Black Memphis. My background drives my research, my teaching, and my service activities, and a lot of my perspective on contemporary and social and economic and political things that happen around the city and around the county and the state. So I'll just give you a little bit of background real quick. I was born, raised, and have spent most of my life in Tennessee, and particularly Memphis, and my current home in Germantown. So I've been here around this place for a long time. And not only have I been here, but my paternal family has been in Tennessee since the middle of the 1800s. My maternal family, my mother's family in Tennessee, West Tennessee, Mississippi, northern Mississippi, since the middle of the 1800s as well, and the early 1900s. So this is literally my home. This is, you know, when I think of what is my home base, except for 14 years in New Jersey, I've always been here. I'm also a 3-time graduate of the University of Memphis, Memphis State University. I should reverse those because those 2 universities in this city have been existing in that order. So Memphis State University, University of Memphis. When I tell people that, sometimes they think that there are actually 2 major universities called Memphis State University of Memphis in Memphis. So it's a little confusing. I've been a teacher for more years than I plan to claim on this particular format for in most of my life, either as public school or at the University of Memphis. And I've been doing this since I was a small child. So, you know, it's a natural by now. You all are supposed to smile and understand that I don't really mean I've been teaching since I was a small child, although I probably have. But building on this theme of Tennessee and Memphis, most of my research and my writing has been on topics related to that. A 2-volume, co-edited a 2-volume series on Tennessee women for the University of Georgia Press. And then a book with my colleague, Dr. Susan O'Donovan, on the 1866 Memphis Massacre. And then with my colleague, Jan Ann Sherman, who is with us today. She's retired from the University of Memphis now. I have done books on Beale Street, Memphis in Black and White, and 2 books on the history of the University of Memphis. So this is home, and I am always very concerned about things that happen in and around Memphis. And of course, like most Memphians and most people across the country, this whole coronavirus pandemic and the way in which governments have dealt with it have brought about a lot of serious concerns. And I have with me on this panel today, I've been able to bring in 2 of my former and present students, one former, one present student, who also share some of these concerns. So for the sake of this particular panel discussion, you can call us the 2 Beverlys, or you can refer to us as Beverly B and Beverly T, or Dr. B and Dr. T. So just to avoid the confusion, but we're in the same department and our colleagues have managed to figure out how to separate us. So Beverly.
Thank you, Beverly. But yeah, so hello, everyone. Like Dr. Bond, I am also a historian and also a Beverly. And it's okay to skip pronouncing Tsakoyanis. If y'all want to call me Professor T or Dr. T, that's fine with me. I did want to apologize. I have seasonal allergies, so I might mute and like cough into my tissue. But anyway, so kind of connecting to what Dr. Bond had been talking about, she comes at this as an Americanist, someone who works in African-American history and is very connected to Memphis. I'm from New York City, but I've been living in Memphis for a few years, and I come at this through my academic training as a historian so I work on history of science, medicine, and technology, and I teach courses on world history, Islamic history, Middle Eastern history, but mainly the focus that connects me tonight to this material is my work on ethics and medical treatment. And I have my first book that is due out in June with Notre Dame Press. It's about conflict and healing in Syria and Lebanon. And my material approaches the sometimes fraught relationship between biomedical and popular healing advocates through the lenses of trauma studies, disability studies, and cultural studies. So Dr. Bond and I put this panel together because one of the most important reasons I think for studying history is to consider the ethical implications of what has changed over time and why those changes occurred. In my teaching and research, this includes questions about ethics and treatment, about who has the authority or legitimacy to decide how others should be treated, and in what spaces do conversations arise demanding change. Obviously, scientific racism has left destructive legacies all over the world, but in the United States, there are also specific legacies around the way in which racism was a building block of this country and its political, educational, and medical institutions, among other systems of power. So with that, that's kind of where we developed the interest in pulling this panel together. I'd like to just briefly introduce, so I will briefly introduce Dr. Irma Singarella, and then she'll have about 15 minutes to give her presentation. And Dr. Bond and I will share the moderator role. First is Dr. Foster, Dr. Letoshia Foster, who finished her PhD in our department and is a nurse practitioner. And then I'll introduce Dr. Singarella, and she'll give her presentation. So it's Dr. Foster's presentation first, then Dr. Singarella's presentation, and then Dr. Bond will introduce Commissioner Sawyer, and then she'll give her presentation. And then if you can put your questions in the chat, we'll come back to the questions after the three panelists have finished their presentations. And also, I have to say, I'm very inspired by the turnout. There were over 100 people that registered on Zoom, on the Zoom meeting alone, and a lot more on Facebook. So I do want to remind people that this event is part of what Dr. Bond and I see as an ongoing conversation. And we want some real change in Memphis. And we look forward to hearing from all of you about how to help make that happen. Please, Dr. Bond, if you will introduce Dr. Foster.
Okay, this is a great pleasure to introduce Dr. Foster. I don't really know whether she's done one of these panel presentations before, but it's a real honor to introduce her because she has been my student. Dr. Foster is a historian. She's an anthropologist. She's also a practicing nurse. So all of this, she comes at this from a lot of different directions, being in the field, but also observing the field. Most recently, she got a PhD from the University of Memphis History Department in the fall of 2020. Her research and her dissertation focused on health and disease among African Americans in Memphis, particularly African American women in the 19th and early 20th centuries. Her work centers on morbidity and mortality among African Americans over what she describes as a 70+ year period. And her research suggests that medical care and treatment during this period, up to the early to the mid 1900s, was traditionally race-based. Many of us might say it's still traditionally or currently race-based. She also looks at the development of the African-American medical community in Memphis, the physicians, the nurses, what many people don't really recognize as an African-American or a medical school, the West Tennessee Medical School, she'll have to tell you if that's the correct name for it, but an African-American medical school that existed in Memphis in the early 1900s. I should also mention again that she has been my student for most of her tenure at the University of Memphis, in addition to the anthropology department, because we did share her for a little bit of time. She is a trained nurse with several certificates or certifications with an MA in anthropology. And she is the person who has expertise on the topic. I'm just simply her mentor and her advisor, but she can tell me a lot more about medicine in Memphis. And in fact, I think one of the major differences of opinion that we had over many years was that she continually came up with all of these great primary and secondary sources. And I had to kind of say, Tosh, please just write the dissertation. Don't fall in love with your sources, write the dissertation. So there's a lot out there that she's looked at. So Dr. Foster. You're muted. You're muted.
Okay. I'm going to address some of the social, cultural, and historical issues of health disparities, and I'm going to look at COVID-19. In 2020, COVID-19 was the third leading cause of death in America. Primary cause of deaths is heart disease and then cancer. Cases in Shelby County, we can look at gender, and we can also look at race. There are more women diagnosed with COVID than men. In terms of age groups, the majority of COVID cases here in Memphis, about 80% are those under the age of 60 years old. In terms of mortality, health disparities, African Americans have the highest rate in Tennessee, 171.6. Out of all the cases, African American women represent about 55 to 57% of the cases of COVID that are diagnosed. When we look at gender, men die from COVID more than women. But when we look at gender for COVID in certain regions, what we find is disparities within the race. For example, more men do die from COVID-19 than women. But in certain areas, Georgia and Michigan, Black women are 3 times more likely to die than white men and Asian men. The only other group to die more are Black men. Historically, we can look at different groups in terms of their health care. Their health care was poor prior to COVID pandemic. So you had these racial groups with health issues, and then comes this pandemic. Certain occupations place people at risk for COVID. When we look at the primary morbidity conditions that place patients at higher risk, the problem within the African American race, those diseases are already high risk. They already place African Americans with health disparities. If we look at cancer and heart disease, it is important to understand that African Americans have a higher cancer burden and face greater obstacles to cancer prevention, detection, treatment, and survival. In fact, Black people have the highest death rate and the shortest survival of any racial or ethnic group for most cancers in the United States. So if cancer is a risk factor for COVID, when you place this pandemic within certain communities that are already stressed, what we find are issues with access to health care, treatment, delay in testing, restrictions on topics or restrictions on the immunizations. Looking at health disparities or COVID within African American women, when we look at cancer, Black women are 40% more likely to die from breast cancer than white women, and twice as likely to die if they are over 50. Again, you have high risk populations already, then you have an epidemic. Shelby County has the highest rate of heart disease among African Americans, cancer, HIV. These health problems, again, were already here prior to COVID. One of the things that I find in my research that's consistent over time that burdens any community is poverty. When we look at the rate of poverty in certain areas in Memphis, on top of that, you have issues with transportation. Again, access to physicians, access to specialty care. All these place a burden on patients, communities, caregivers. These are historical issues. We have to figure out and address race as a primary factor that continues to produce poor health outcomes in communities. Americans continue to live in racially and economically segregated neighborhoods. 75% of whites still live in a neighborhood where 75% of white people live. African American neighborhoods are similar. Health risk is worsened when you have segregated communities. Race produces this idea of segregation and inequality. Race spills over. Racism and institutional racism spills over to other things, and healthcare is now one of the biggest ones where you see race being used to deny treatment, to what we call produce negative health disparities. Even if African Americans live in a neighborhood where the hospital is top rated, doesn't mean that they have access to enter those hospitals or even have surgical procedures. We can also say that among our Hispanic population who lives here in Memphis, the additional burden for disease based on race-based healthcare. Is there anything else? I wanted to be quick. I didn't want to take over too much time. But in American society, race is detrimental. Being an African American is a risk in and of itself to have poor outcomes based on what we see in the data.
Dr. Foster, did you want to share the slides now, or did you want to
I
wait?
tried to click and it asked me to log in and I wasn't sure. You can't see them, can you?
Oh, click on share screen at the bottom and then click on the
share screen.
Yeah, and then it'll bring up a couple options of which screen you have open to share. So if you click on the PowerPoint.
Okay, I clicked on the PowerPoint. I see share at the top. Share this document and see, and oh gosh. Okay, let's see. Oh my gosh. I can email, maybe I can email them.
That's what I was going to say. If you can email them to me, then we can move on to the next presentation and come back because we got tons of time.
Okay, beautiful. I'll go ahead and do that. Okay.
Thank you so much, Dr. Foster. I mean, we've got, and we'll be coming back to a lot of the material you talked about in the Q&A for sure. It's really awful statistics, and it's unfortunate that not much has changed in the last like 50 years. You really would, I would have hoped that there would, anyway, we'll be talking about this. I wanted to segue just to Dr. Singarella's material because as you all know, Dr. Foster has worked as a nurse practitioner and a historian and an anthropologist, and we also have within our ranks today a health sciences librarian. So we're coming, and Commissioner Sawyer. So we've got a very interdisciplinary panel here. But just to quickly go over what Dr. Singarella has worked on, Dr. Irma Singarella provides leadership and direction for the overall operations of the Health Sciences Library at the University of Memphis since August of 2017. And as a member of the faculty, she participates in research activities, the university library's collection development program, and serves as a subject liaison. She provides users assistance and research support to faculty and students. Some of her academic appointments are Community of Researchers Scholars, Health Spaces and Technology Research Community Member since 2019, Liaison Librarian, Lowenberg College of Nursing and School of Communication Sciences and Disorders since 2017. And Dr. Singarella has also recently, along with a few other panelists that participants that are here, I see Dr. Lee is here as well. Dr. Singarella is with Dr. Lee and Dr. Williams, Yaisha Williams, part of an NIH subgrant that I hope, I'm sure she will be going into a little bit more detail about. But also at the beginning of the chat, Dr. Singarella mentioned that she's, as part of her research with the NIH, the National Institutes of Health, she has the 2020 Community Health Needs Assessment Survey. So we really encourage people to click on that and be part of the data collection. Please, Dr. Singarella, the floor is yours.
Thank you. Thank you very much. I'm so honored to be here. I'm going to share my screen now. And I'm from Puerto Rico. I've been here, like you mentioned, since 2017, and I'm still learning. This has been a great experience. And part of that experience is to work with a great team of researchers. We have an outreach project with the Memphis Public Libraries. So I'm going to talk a little bit of my project, our project. And these are the topics for today. I'll go ahead and my next slide. And I have a picture of Miss Eleanor Roosevelt, and she's holding a poster of the Universal Declaration of Human Rights. This document represents standards of behavior for the entire world and mutual agreement to respect the universal dignity of human life. Other countries have also added legislation, and we believe as librarian, as a researcher, that information and information access are important for the development of every human being, and it's a basic human right. Different organizations, including UNESCO and the World Health Organization, the CDC, have mentioned the importance of health information, especially during this pandemic. We have seen that unfortunately the digital gap leads our communities to poor access to information, poor access to services. And I'm going to share a definition of health literacy. When we talk about personal health literacy, we talk about the degree to which individuals can find, understand, and use information and services to make informed health-related decisions and actions for themselves and for others. It is important to develop information literacy skills, health information skills, and professional organizations like the American Library Association also promote the information access as a basic human right. But we have a big challenge, and it's our background. We have a lot of misinformation. We have a lot of bad health information, horrible content available. And we live in a diverse community. According to the United States Census Bureau 2019, Shelby County's population is 54% African-American, 36% white, 6% Latino, 3% Asian, and 1% is identified as other. And we have special challenges because every community is diverse. When we talk about Latinos, for example, I mentioned I'm Puerto Rican, we are so diverse and we can have different challenges and cultural needs. So we still have to do more research in order to satisfy all those needs. And as measured by the American Community Survey, this was pre-COVID-19, the poverty rate in Shelby County was more than 20% compared to the Tennessee rate of 15.8%. The city of Memphis had a poverty rate of almost 27%. And this is almost double the national rate of 14.8%. We have more facts here. The city of Memphis has a poverty rate of 21.7%, and the child poverty is 35%. So the children are poor because their parents are poor. And even when we see that poverty has decreased for all ages, this is still very, very high, especially for Latinos. Poverty rate for Blacks is 26.1, and for Hispanic Latinos, 29.2. And it is noted that this year, Black and Hispanic Latino poverty rates are very high and converging in Memphis. It is now observed, it's been observed for several years that poverty rate among non-Hispanic whites is lower in Shelby County, and poverty among non-Hispanic whites is much lower than other groups, and the poor tend to be minorities. The poverty rates for Blacks and Latinos are higher than the overall poverty rate. So we have elevated poverty rates. It is very difficult for young people under 18. And in Shelby County, almost 35% of youth live in poverty. The rate of racial wealth disparity has not been improved in more than 50 years. And we know that income inequality translates to unequal access to education, resources, food, and healthcare. Also, low-income communities have problems with transportation, and the cost remain a significant barrier for many families. So what should we do about this? As information professionals, as researchers, we provide services, and I'm gonna mention a little bit of, about our services at the university libraries. Sorry. The Health Sciences Library is a branch library of the university libraries. We provide online and in-person services, and we try every day to provide excellent services. And that's how we develop informed individuals, informed communities. At the Health Sciences Library, we are members of the National Networks of Libraries of Medicine, and we provide access to the tools that the National Library of Medicine develops, for example, PubMed. And we have seen an increase in different articles and research about COVID-19. Actually, there 4% of research around the world is about COVID-19. So researchers have been working hard, developing content, developing evidence for our researchers, for our health professionals. And like I mentioned, I'm honored to work with a group of interdisciplinary researchers. So I'm here at the Health Sciences Library, but I'm also working with this incredible team. We have researchers from nursing. We have researchers from social work, education, and two wonderful students, one graduate and one undergraduate. We have an outreach project with the Memphis Public Libraries. The Memphis Public Libraries serve thousands of users. They also offer excellent services, and they have 18 branch locations in Shelby County. And let me tell you a little bit about our story. We started developing our research in 2019. We had the concept, we had our protocol, we submitted our documents to the IRB, and then what happened? COVID-19 interrupted the process. We were ready to go to the libraries, and we wanted to have a hybrid process with some online surveys and some paper too, to survey the people at the branch libraries. But we needed to move everything to the online environment, and we submitted our documents once again to the IRB, and we got our approval. So we are collecting data. You received the link, is in the chat, and the criteria is if you are 18 or older, you're using or willing to use the Memphis Public Library services, you can participate. Our purpose is to gather feedback about the health needs of the Memphis community and the ways in which the library systems help support those needs. We have compensation for participants, and it's something that we all need now is masks and hand sanitizers. You can also donate those items to the library. Our focus is on health promotion. We are still collecting data, but we have some preliminary results here. As you can see, our participants are diverse in age, mainly 25 to 34. And these are their ethnicity and age. We have 85 white participants, 40 Black or African American, 11 Asians, and other did not identify. We ask which of these behaviors and conditions they will be willing to receive from the library, and our participants said that they wanted information about healthy eating, reducing stress, increasing physical activity or exercise, and weight control, among others. They would go to get information about health on the internet, the television, and their health professionals, which is good news. So we identified these needs and areas, and we developed an outreach project. This project is called the Help Us Project, and is to improve information access. We are still working on it, but we developed a research guide. The university libraries has a list of excellent research guides, and one of them is about COVID-19. So our project is adding information, and we are providing training. We identify mental health as one of the needs from the community. So one of the instructions is about ACE, or adverse childhood experiences. And the other one is about suicide prevention. We still, we know that we have some challenges. We have to develop access to technology. We're working with a community with low levels of health literacy, misinformation, and lack of trust. And COVID-19 has further diminished equitable access to information. We have a digital inequality situation, which prevents many from participating in available online services. And those who need the library sometimes don't have access. So our next steps is to keep researching, developing our services here at the university libraries, and with outreach projects, multidisciplinary teams, promoting educational activities. And we just ask you to be safe, participate, and support your libraries. These are my references. And thank you. This is a picture of my beautiful San Juan, Puerto Rico.
Thank you so much, Dr. Singarella. I should mention that my mother would have been neighbors of some of your relatives, because my mom is from the Dominican Republic.
Oh,
yeah,
yes.
She moved to the U.S. in the 1960s after the Civil War in DR. But yeah, this is really important material, and we do want to just announce that Dr. Foster's slides are ready. We're going to just save it for the, or actually, Dr. Foster, would you like to show your slides? Dr. Conroy can show your slides, or do you want to wait until after Commissioner Sawyer's presentation? Oh, sorry, the mute button. Sorry.
Every time. Yes, I can wait till after Commissioner Sawyer presents. That's
okay. Thank you so much, Dr. Foster. Okay, and Dr. Bond will introduce Commissioner Sawyer.
Okay, I have a great pleasure of introducing another student of mine. Well, she's actually a student that I share with Dr. Andre Johnson in communications. And I think we kind of share quite a few students. Most of you already know Commissioner Tami Sawyer. I think it would be hard to live in Memphis and Shelby County and not know Commissioner Tami Sawyer. But I'm going to tell you maybe one or two things that you may not really know about her. And unfortunately, she didn't send me her 3 sentences. So I had to go back, Tami, and look at what you put on your introduction for the class, our class. Not everything, but just a couple of things. So just a few things. Number one, she is a 2004 graduate of the University of Memphis with a BA in political science. She briefly attended law school at Howard University, but then she came back to Memphis. She came back to us. Number two, she is currently a first-year MA student in the Department of Communications, where the focus of her studies is Southern Black women, their voices and their bodies. Number three, she has 2 cats. She loves good, robust cheese. And one of her life goals is to travel to countries of the African diaspora. She had already started her travels when COVID kind of shut everything down. I think you said you were headed to Ghana, you've been to Cuba, you've been to Kenya. So she was, in fact, you've been to the 3 that I've been to as well. So I know you had a great time and you learned a lot. And she was moving in the direction of continuing her travels when COVID, of course, shut everything down. And then I think the 4th thing that everybody knows about Commissioner Sawyer is that she is an activist. And for most of us who have kind of been aware of her activities over the last few years, did I mention that she was a candidate for mayor of Memphis? I think I forgot that one. She's currently on the Shelby County Commissioner. She was a candidate for mayor of Memphis. On the commission, I think you said you are the chair of the Committee on Education. Did I get it right? Okay. So she's, all of this kind of comes out of her, her desire and her work to be a change agent. She is an activist. She's just kind of like out there in the forefront, doing a lot of things, or bringing about a lot of changes and addressing a lot of issues that I think maybe other people in Memphis just see and kind of say, well, it'll change. Well, that's not Commissioner Sawyer. She sees them and then she figures out how can you do something about them. So at this point, I think one of the things that she and many other Memphians are seeing are these inequities in the way in which people are addressing the pandemic. The pandemic is here, it's there, but how are people dealing with it? So Commissioner Sawyer is going to talk to us about that. And I'd also like to ask if you would definitely put your questions in the chat. I've seen a couple of good ones that I'm going to claim before Beverly T claims them. So I've already got them. So you can claim the ones that are coming up after this, as long as they're not the ones for Commissioner Sawyer. I'll claim hers. Okay, Commissioner Sawyer.
Thank you so much, Dr. Bond, for that introduction. Let me share my screen. Different. I think most people are used to seeing me in non-academic presentations. So I'm a grad student, y'all. But so my presentation this afternoon is going to be on COVID-19 and Shelby County looking through an equity lens. Dr. Bond, thank you so much for your words, your support, for what I learned in your class and how I'm able to apply that to my daily work as a commissioner, as an activist. So to tell you a little bit about why I'm here, I am a Shelby County Commissioner, which means Shelby County is the governing body for public health in Shelby County. That's not the role of cities, though they do take on roles and play a part through partnerships and other opportunities. So I've been very involved with COVID-19 since before we got the first case in Shelby County. I actually canceled a trip to Ghana when the cases started to spike in New York because I feared I wouldn't be able to get back in the country. And it was from then on that my friends call me the COVID czar. That's my nickname, because I've been very outspoken about the need to protect our community against the pandemic. I'm also a graduate assistant to Dr. Marina Levina, who couldn't be here today because she's actually teaching a class on pandemics right now. Some of my classmates, I'm not in that class, but some of my cohort classmates are blowing up our Slack right now because they're doing their final presentations. We're almost at the end of the semester. If you're not a student at U of M, you wouldn't know that. But my research areas, I was her graduate assistant last semester and this semester. So the research that I've completed and am in the process of completing for her are on COVID-19 and essential workers. What does this language of essential mean? How did we even start calling workers essential? It's relatively new language. Who gets called essential? Is it beneficial to them, or is it, to protect the industries? We've found that this language is mostly created so that certain industries remain open. And by giving workers this title of essential, we found that it's not really about protecting the workers. It's about protecting the bottom line, the business, the financial aspect. Other research areas are this global anti-lockdown, anti-vaccine sentiment. I know a lot of people see like the anti-lockdown protest here, and they think, well, that's related to certain things. I'm going to try to be as bipartisan as possible. Most people know that's almost impossible for me, but I'm gonna get it. But anti-lockdown and anti-vaccine sentiment is not just in America, and I find that in a lot of the circles that I am in, we dismiss it as related to the former president, or we say that's crazy, but it's actually really big across the globe. Lots of protests in Europe, protests in India, protests in Vietnam, protests in China, protests in Japan, where people are tired of the lockdown. They've actually, the number of protests against COVID-19 lockdown has risen since the beginning of this year. Folks are just tired. They want to go back to work. They want to go back to living. And then COVID-19's impact on the meatpacking industry and workers, which is a very specific research area that Dr. Levina is working on. It's important through this equity lens because one thing that I discovered and did not know is that the majority of meatpacking warehouses are either in the South or they are in Midwestern areas. And the majority of the employees in meatpacking warehouses, and so you think very hot, very dense, very dark locations, and they are mostly staffed by immigrants and people whose status may or may not be documented. And these are not just Spanish-speaking immigrants, they're European immigrants, African immigrants from South American countries. But what the meatpacking industry has experienced is a lot of the early spread of COVID-19 can be connected directly to a rash of cases in meatpacking warehouses. So the spread in North Dakota directly connected to the Purdue plant. The spread in Mississippi directly connected to the various chicken plants there. And so we've been studying that and then what that says about the lives of workers as well. Additionally, I am a member of the State of Tennessee's Department of Health Health Equity Task Force. We focus mostly on COVID-19, but we also look at health through the lens of other disparities. So diabetes, cancer, all types of things. And as I'm about to show and discuss, health equity is a larger conversation than one might think. So here are some of the major things to think about when you're thinking about health equity and COVID-19 here in Shelby County. Access to PPEs and testing sites and vaccines. One of the questions that the Beverleys have presented to us is, did Shelby County do a good job when it comes to the vaccine, not the vaccine, to COVID-19 and the Black people? When it comes to all people of color, access to PPEs, testing sites, and vaccines, there always had to be a second wave of access. Initial access tended to go to mostly well-off white people. That is the first people to get masks when we were in March 2020, the first people to get hand sanitizer, the first people to get access to tests. The first testing site in Shelby County actually was a private testing site, and it opened in Arlington. Though it's transportation insecurity is a major issue here in Shelby County. And so automatically the majority of the Black and brown population was excluded from having access to COVID-19 testing until those locations became more widely available. And the same issue with the vaccines. The first locations to open were in central Memphis, which is physically central, but is not necessarily central to marginalized populations, again, with transportation insecurity. Racism as a pandemic. We passed a resolution in June or July of this year. I wrote and sponsored it, and now the CDC has actually followed suit. I found the resolution by reading from the American Psychology Association that racism is a pandemic, because every health issue that we face seems to, well, not every, but a lot of our major health issues impact Black and brown people in disparate numbers because of the compounded issues of systemic racism. And so racism is a pandemic because of the number of Black and brown lives that are lost to things that are avoidable, to things that someone with privilege and with means could take it, not either experience or could heal from. Racism as a pandemic also informs the fact that Black people are living through multiple crises right now. Just say his name, just yesterday, another young man was killed by police officers, so we're living through this pandemic of COVID-19, this pandemic of racial inequity, plus a financial crisis that the majority of the country is facing. Vaccine insecurity. How are we communicating with and encouraging people to take the vaccine? About 34% of adults who live in Shelby County have been vaccinated as of today. And we have a national goal of 75% of our population. And it seems like we've kind of slowed to a crawl in getting from that 34% to that 75%. Whereas at one point there was high demand for the vaccine. Now that it's open to all people, we're seeing that we're not filling more than one third of vaccine appointments a day. That's not necessarily the fault of government, but it also goes back to how are we looking at things? Who are we talking to and how are we talking to them? And what are we saying to people about the vaccine? We can't just assume that people automatically know that the vaccine will save their lives, that the vaccine will protect them, that the vaccine will have help them, keep a job and go to work because they don't have to worry about illness. Black and brown people have very understandable and real fears rooted in medical apartheid, and public health needs to be able to communicate through and about that. But also, we also have an issue where we over communicate about vaccine insecurity in communities of color. The demographic that's most likely not to get the vaccine are white males who identify as conservative or Republican. 40% of white males who identify as conservative or Republican refuse to get the vaccine, whereas with Black people, it's about 19-20%. Someone can correct me on that second number, but it's almost half of the latter. School conditions and forced reopening. One of the biggest issues, and this is the same issue when I get into inmate health, is that our students and our inmates are housed and educated in buildings that are almost deplorable. Lack of ventilation, access to fresh air, mold, asbestos, lack of access to fresh, clean water, lights, all kinds of things that, if you spend some time in an aging Shelby County school, you would be concerned about the day-to-day health before pandemic and after. And so school conditions are not best for our students. And so when we push our kids back into schools and we put up these plexiglass separators for them, but they're still breathing non-circulated air, we have to do something with these buildings to modernize them so that kids can actually not spread or contract COVID-19 and any other viruses. Inmate health, the ACLU just issued a report today, which showed only 22 inmates held in 201 Poplar. These are actually not inmates, they're detainees, people who have yet to be convicted of a crime. They've just been charged. The majority of them are held for poverty. They're unable to pay their bail. And we're at 40% of them have bail that's less than $2,500 and they can't afford to pay that 10%, which is $250. Only 22 of the inmates, where there are hundreds of them at 201 Poplar, have received the vaccine to date. And they, in over a year since the prisons and jails in Shelby County locked down, an independent auditor found that inmates and detainees in our felony prisons and in our jails are not allowed to do outside exercises. So that contributes to their wider health. And one other thing to note is that this is more than black and white. We talk very often about Memphis and Shelby County through the lens of Blackness and whiteness. I had this conversation with Dr. Levina today, but we have a quickly growing immigrant population. Shelby County is one of the fastest locations for growth of a Latinx population. And so we have to be able to communicate with our population about health through multiple languages, and also think about cultures. Think about how we address women who are in hijabs. Think about how we dress, people who are speaking language outside of what we consider, we translate in English and Spanish, but there's over 21 major languages that are spoken. More than 10% of the population speaks in Shelby County. And so how do we reach outside of our conversations of black and white, this growing population of what would be considered other before now? I'm going to go through this really quickly because I realize I'm at time, but I wanted us to think about the economic language that we're having, because a lot of the pandemic conversation is about back to business. The Shelby County government and the city of Memphis government and the municipalities launched back to business. To me, it should have been more people focused, because while we want our economy to thrive, our economy can't thrive if our people are still insecure as far as their health. Luke Bradstreet was interviewed, and he was an employee at Kroger, and he says, people said we were essential, but it feels like we were sacrificed. So the people who had to work throughout the pandemic still aren't making the living wage, still are being faced with people coming into their stores and their restaurants without wearing masks, never got to shut down, never got a chance. And then they were put in later phases for vaccine access. So your restaurant workers weren't on the initial phase list. Your grocery workers weren't on the initial phase list. Teachers weren't on the initial phase list. So we called all these people essential and demanded that they work through a pandemic while a lot of us were at home in pajamas, and they fed us. They literally fed us. They dropped our toilet paper and our good cheese on the porch. They dropped our Five Guys burgers off, and, they had to experience the world. And we said, you're a hero, you're essential, thanks for keeping our economy going. And then we wouldn't even reward them with access to the vaccines. One other thing is that we have to remove classism from our conversations about economic recovery. we can bail out businesses while we're also thinking about our employees. There's a lot of language going around right now about laziness, and this just happened today. We're out back on Union, started a flyer on their door by saying that due to the stimulus, people don't want to work. And I've seen it over and over again on social media where people are saying that food service is slow right now because people are lazy because they got a check. If we're going to begrudge a $1,400 stimulus check and think that that is what's keeping people at home, when in reality, what happened is people had to go get other jobs. So maybe they found a job that paid them more than $2.31 an hour. Maybe they found a job that paid them $12 or $15 an hour. They had to find a way to get childcare. They had to find a way to keep their transportation. It's not that people are lazy. And this lazy language goes right in line with very race baiting, dog whistling language that aligns with, as Dr. Singarella outlined, the demographics of our city and county. So when we think about who we're talking about when we're talking about lazy workers, we're talking about Black people, and we're feeding into the trope that they're lazy. This is where we have opportunities for improvement, which is the final question. I believe we need to rehab and rebuild our schools. That's a long-term project. It needs to be urgent. We need to be aggressive with the types of jobs and wages. Warehouse jobs are not going to keep people healthy. They're not going to allow people to get educated, and they're not going to allow people to pay their bills. Our transportation insecurity in Shelby County is shameful. People can't get on a bus to access vaccines. When we had the water crisis during the snowstorm this year, I was literally driving my car to go to people's houses to drop off water because people couldn't get to water, they couldn't get to the sites where we were giving away water. The issue with transportation access keeps people unhealthy because it keeps them siloed in food deserts, transportation deserts, and healthcare deserts. And finally, how we communicate about health, making sure that we are communicating directly with people, recruiting people to take the vaccine and get tested, and also making sure that we're talking to the cultures outside of the identity of Blackness and whiteness and American. Thank you.
Thank you so much, Commissioner Sawyer. There's a lot of important stuff that we can unpack in there, but I want to just quickly come back to Dr. Foster's material before we switch to the Q&A, including Dr. Bond addressing the first few questions in the chat. Dr. Conroy, can you click through for Dr. Foster?
Yeah, so I'm going to share this, and then if Dr. Foster can maybe talk us through some of the key points, because there's a lot of really good information here. So what precisely are the key points, and I can continue to click through once it opens. Okay, so is there a particular slide or?
Dr. Bond did the introduction for me for this one. This was about my research. Perfect. I focused in on enslaved women. I also addressed African-American women's issue in terms of psychosocial health. We think of health more than physical. Psychosocial health is very important. We see this in the time of the COVID pandemic. What does isolation do? What does being in a house, just the limited contact? The benefit of Zoom is wonderful, but people are getting more and more isolated. The fear of going out too, the fear of touching, the fear of all these things. I addressed some of the psychosocial issues for women during the Memphis massacre. Also, Dr. Bond discussed the medical university, the University of West Tennessee, nursing training schools that opened for African Americans in the early 20th century to address racial and health disparities. There were high mortality rates in Memphis. Men, women, children, tuberculosis was high. In the United States, I kind of looked at a theme in the United States. Race is a powerful determinant of health outcomes. Health disparities for African Americans are historical and institutionalized. Racially constructed ideologies of inequality and privilege penetrate social institutions, as I said, healthcare. Disparities in healthcare are common across American cities. I kind of went over COVID in terms of the third leading cause here in America. Those are some of the numbers. Okay, confirmed cases for Shelby County. This is for a white population. I just gave that data. I kind of went through groups of people, younger people getting sick lets us know that they are not in good health to begin with. Health issues of chronic diseases. I also touched about the mortality rate of African Americans in relationship to COVID. Okay, and this one was for the white population, the total number of cases. Hispanic make up 6.2% of all cases, 6.7% of the hospitalizations, 2.6% of deaths in Tennessee. No new cases reported unless they're slow at reporting. Okay, for African Americans, the death rate at 7.2%, and they make up 17.1% of the population in Tennessee. New cases representing 12.8% of new cases of COVID. And again, gender, more women than men, but men are dying more in terms of COVID, especially in hospital settings. Here we go, it's Hispanic population. The number hospitalized, men are dying at a higher rate than women when hospitalized. Again, we look at gender in terms of African Americans. Those are good. Those are the death rates. Okay.
Sorry, I'm not clicking it. It's going on its own.
You're good. You're good. You're good. I kind of covered some of these. Look at women individually, the health risk.
Okay, great.
Okay. Cancer disparities. I don't know. It just seemed to be. You could probably stop it. We could do questions and answers if you like, because it's just repeating.
Okay, great. Thank you so much. But wow, those are some really, really terrifying statistics. Very sobering statistics.
Foster, you've done some really impressive work here, and I'm hoping that people will reach out to see the data that you compiled if you're willing to share it. Oh, sorry, I was just going to say everyone should look forward to reading Dr. Foster's book when it comes out, hopefully in a few years. I know it can take a while to get from the dissertation to also medical professionals, but you'll find her hopefully. But Dr. Bond, did you want to? Oh, sorry, Dr. Foster, I also interrupted you. What were you going to add?
I was going to say Methodist Le Bonheur and the Robert Woods Johnson Foundation are good sources for data on healthcare in Shelby County. They did a comprehensive health analysis.
Okay, I can go ahead and start with some of the questions. And it occurred to me as we were looking at Dr. Foster's slides that they were a good tie-in with what Commissioner Sawyer had just said, because I don't know, the thing that our course that Commissioner Sawyer is taking right now is on 19th century African-American history. And it just always occurs to me as I'm going through this material, that old saying, the more things change, the more they remain the same. And I think having read through Dr. Foster's work, that's some of what you see, that some of these things are similar. They're not exactly the same, but they are similar. Who's impacted? How are they impacted? How important is communication? How important is, I guess, transportation? All of these things. And then just to kind of look at the first two sets of questions that were in chat. And I think these could be for either of our panelists, so you can kind of think them over. The questions that Charles Belinky asked, if you want to just take a look at these. And his question, I wrote it down, even though I could probably just kind of read it from this. He said, do very affluent Black Memphians also have limited access to healthcare as compared to very affluent white non-Hispanic Memphians? Or do the differences converge at the top? And I would like either to respond to this. I have my own ideas on it, but I think there's an intersection here that maybe people who work in sociology, people who work in anthropology, and and historians that we always kind of think about. And I think this was even what Commissioner Sawyer was ending with, that very often it's not a question, it's not simply a question of Black and white, that race is one set of criteria, but there's something else at work. And I think Commissioner Sawyer was mentioning that this could be, and also Dr. Foster, that we have to consider the immigrant population in Memphis. But I think we also have to consider, issues of class and how those issues of class relate to all of these other factors that we've been looking at. So I would ask either of our three panelists to respond to Mr. Belinky's comment.
I can jump in really quickly. I think it's a both and answer. Hey, Charles. I think it's a both and answer. I think so. I'll just tell a quick anecdote. I'm in an organization called The Links, which is a for Black professional women and Black women, traditionally Black women of a certain class identity. And I'm second generation and all of these other things. And I remember in the group me, they were always texting around, here's where you can get your vaccine, here's where you can get your vaccine. And someone would have access to that information because their husband was a doctor or they were a doctor or somebody was in public office. And it was very different than what was happening with my constituents on Facebook who were always, where can I get the vaccine? Why is the vaccine not in Fraser? Why is the vaccine not in Raleigh? So yes, there's an economic advantage for upper class Black people. But then when you think about treatment, when you see me, you don't know what's in my bank account, right? I have a bruise on my arm because last week a nurse did not believe me when I told her that I can't get an IV in my arm. She has to put it in my hand. And I overheard her tell somebody that I was just complaining for no reason and was scared of getting the IV. Instead of realizing that I'm 38 years old and I know my own body, she dismissed me. And that happens to people of color and people who don't speak English very frequently. And so, she ended up having to put the IV in my arm, but a week later, I still have a bruise that's almost 2 inches long on my arm and a broken vein. And that's just an anecdote for you to understand, yes, classism exists and upper class Black people probably do get better access to healthcare initially. But once we get in that emergency room, once we get in that operation room, you don't know my degrees, you don't know my income, you don't know anything about me. So what your misperceptions are of our skin color are going to lead how you treat us.
I can also address it from an issue of medical insurance. There's a belief that when you work, you have a good paying job, you have this insurance. This insurance entitles you to go to a particular hospital, get the best medication, get the best treatment. But the reality is your insurance is going to dictate where you go, what medications they're going to pay for, regardless of your income, because you fall under a certain plan. Now, you can explain to patients that they can't go to, quote, a place that they perceive to get better care, but do you want the bill? And I can think of a colonoscopy. I have patients, well, no, I don't have to get it here. I can go elsewhere. it's $1,200, yes, but that anesthesia bill is about $10,000 to $15,000. That's the reality that you get when you, it's just a belief. Yes, I think that class matters, but in healthcare, we have to educate patients. We have to educate the public about what you're really getting in terms of healthcare. Are you getting basics with preventive care? Do you want a little more? And in terms of health disparities, it doesn't guarantee me, since if I have money or a middle class status, that I can walk into any hospital or medical clinic that I choose, because that's just not the case.
And I think I would also add, and I may not have all of the information on this, but I remember last spring, I believe, there was a Black doctor, female doctor, who was admitted to a hospital with coronavirus. And she was telling people, telling her colleagues, other doctors, what was wrong, but they did not listen to her. And she was a medical doctor. So class, you would think in that case, as well as information systems that she had available to her, it just didn't pan out. It didn't come through. And she ended up dying of coronavirus, while all of the other medical community was standing around her thinking, well, she's just another African-American woman who's just maybe this bossy or I guess angry Black woman. And what she was angry about was that she knew that she wasn't getting the care that she should have been getting. So all of these things, it definitely may not be just simply race, Black and white. Class may be in there, education may be in there, but that's not a guarantee. And of course, we will not even deal with the Social Security systems and Medicare. Well, that's a whole nother ballgame.
Yeah, Dr. Bond has, and Dr. Foster and Commissioner Sawyer have pointed to some really important material here. Just to connect to what Dr. Bond was saying, that she's talking about Dr. Susan Moore, who was denied the appropriate level of care and did die from COVID, even though Dr. Moore was a physician. There was a study in the journal for the Proceedings of the Academy of Sciences, the PNAS, about racial bias and pain assessment and treatment. And this was by Hoffman et al. It was from 2016, and they polled current practicing physicians in a variety of spots in the United States. And medical doctors actually, not as high a percentage as the general public that they polled, but medical doctors did, in their data, think that Black people did not feel pain as much as white people. And these are currently practicing physicians in the United States, and that Black people had thicker skin. And I assign that to my science and technology and world history class every year because it shocks them. I have students here at the University of Memphis who are expecting to major in STEM fields, who just have this anecdotal evidence about systemic racism and the problems and how racism is a public health issue on top of a lot of other issues. But the racial bias and pain assessment is a longstanding and continuing problem, which is, and somebody had pointed to Dr. Thomas had asked, Elijah Thomas, what are some solutions to ending systemic racism in workplaces and in many medical institutions? I would say it has to start also in the schools. Like the medical schools need people teaching that there is a racial bias in pain assessment, and that race is a construct and it's not a genetic fact. Like there's nothing scientific about race. I'm sorry, this gets me on this like whole thing because I'm a historian of science, but I'm gonna just see if other folks wanted to jump in. Also, and then connecting to what Charlie had said, yeah, absolutely what Dr. Foster and Commissioner Sawyer were saying. It's not unique to Memphis. It's all over the United States. And I've seen it in colorist societies elsewhere, in research about medical access in Brazil, all over the place, where darker skinned people are treated as if they don't feel the way lighter skinned people do. And it's the kind of thing that it's a problem for everyone. It's not a problem just for darker skinned people. It's the level of care that, for example, what Commissioner Sawyer said with the anti-vaxxers. I mean, the FBI had done research on this. You can look this up, that there was chatter on white supremacist websites that they should unmask and be everywhere they could be, so that the people who had higher morbidity issues would die. I mean, I know this sounds ridiculous, but the FBI has data on this, on the supremacist chat boards. But it's a form of ethnic cleansing that has its roots in scientific racism. But anyway, I'm going to just jump to other people because I can talk about this forever. But
Okay, let me go back to another one, and this
I
was.
would like, if I just want to add something about hospitals quickly.
Oh, okay.
It's the system can be very intimidating, and if people with degrees go through those horrible experiences, can you imagine how a person with low literacy feels? I mean, it's very, very intimidating, and hospitals can be very dangerous places. So there are reasons to feel scared sometimes. Information is very important. And once again, health information literacy. Thank you.
I think I was going to ask Mr. Thomas's question, Elijah Thomas, which is tied in with, I think, the same thing. Are there any subtle factors in hospitals that can affect African Americans' feelings of safety while attending these hospitals? And I wanted to kind of ask that one because that's looking more at this from an idea of feelings. How do people feel about being in hospitals, or feelings even during this period of the pandemic? How is this affecting even the willingness to get the vaccine? Because sometimes it's not just the knowledge, it goes beyond this. A person can know that the vaccine is good, or that it's going to be to some degree a preventative, or make it possible for you not to die from coronavirus. But what about those feelings that you have about, what if I have to go to the hospital? What's going to happen, especially when you cannot be surrounded by people that you know, your agents or whatever, family. So I see Dr. Foster nodding her head. So Dr. Foster, Dr. Singarella, Commissioner Sawyer. Mm-hmm.
I know working, there's a fear in the African American community, excuse me, about a conspiracy that seems real and it seems valid. I have patients. How do we know what we're getting? How do we know that that particular vial didn't arrive at this hospital and there were different ones going to another place? And for people who have experienced racism, that is so real to them. Even the COVID test that they have to take. Are you sure that when they put the Q-tip in my nose, there's not something on the end of it? I mean, can they really be giving me the virus while they're doing the test? And you sit back and say, you have to explain, but it's real. I'm not going to take it away because they come with it. It's in the community. It's being discussed. Tuskegee, I don't think any millennial really know, but they tell me about it. When I see a 20-year-old who knows that story, who can tell me about it, those fears are still real in the community. They were real for me as a provider, for coworkers. There wasn't an immediate need to take that vaccine. There was a more of a let's see and wait and kind of see where this is going first, and then we'll decide if we want it. And for the lay public, now they're talking about the Johnson's vaccine that they don't want on the market, and we're trying to convince people about the benefit, but there's a reality that people see, that they hear. And that is something that's difficult to maneuver, but you have to help them through those processes, especially if you've been through them. I can tell the patient that the vial is open, that you know it's sterile, because you're going to watch them unwrap that in front of you to get the COVID test. But the fears that are in the community and the uncertainty, I think those are real. And how you're going to get that past that. Race is an uncomfortable issue to talk about, especially sometimes at work. There's this sort of fear that people have when you bring up racial issues, that they view you as being a racist person because you want to address race as an issue. Racism needs to be addressed if you're addressing race as an issue. To me, that has to come across really clear. The difference in our society, there's an understanding of who could be labeled a racist, who can't, who can have a title of being prejudiced within certain groups, but not being able to consider themselves as being racist, or to follow or to carry out those threats and issues. But in healthcare, I think with COVID, fear for a lot of things are real, and I don't think it's gonna leave for a while.
I'll just add quickly, one thing is we have to bring public health to the public. It's just like, the same way kids know that their school in North Memphis is not as nice or as technologically savvy as a school in Collierville. When you look at hospitals, what do the hospitals in Collierville look like versus if you have to go to University Hospital or the Med? Why are there metal detectors to get into the ER at the University Hospital? My parents won't go to University Hospital because unless they end up in an ambulance, but my mother refuses to just be taken there because she believes it's a slap in the face to her dignity and the dignity of other people, that this hospital in the middle of a Black community, you have to walk through a metal detector. And sure, you could find all type of justifications from that, but if you want people to be more comfortable about their health care, why are the chairs harder? Why are the people meaner? I get yelled at University Hospital. I get greeted warmly at Baptist East. So how we treat people plays a role in what they experience in the customer service of healthcare. Why do I have to get on a bus to get a vaccine? Why do I have to get a ride to get tested for COVID-19? And it goes back to that health communication as well.
And then in certain states, public health systems are really strained. In other states, they really thrive. In California, you have this magnificent public health system where nurses are probably going to go out to give, the vaccines to homebound or people who don't have transportation. But when the system isn't large enough to cover so many needs within the community, it's difficult to do that. And for me, I've been a nurse for 36 years. Nursing training has changed. There's this overemphasis on more of technique and skill versus more of culture in health, theories in health. How do you take care of populations? How do you bring into healthcare a person's own belief? Personal beliefs are very important. I had a patient, a Hispanic patient, who told me he had COVID and it was a tea he mixed with 2 or 3 aspirin, which makes sense because a lot of aspirin has anti-inflammatory. So whatever he did worked for him. But in our society, would he be confused? Well, you should have come in because you could have passed it on. You could have passed it on. Healthcare, the biomedical model of healthcare is sometimes harmful. And with our patients, we have expectations that they do what we say when we do take the medicine like we ordered, don't skip a dose, but they forget about all the side effects of all the medications they're taking, and then they wonder why they didn't finish medications. So there's a lot of teaching and education to go on with it. And then on top of that, they tell you have 15 minutes with the patient. Healthcare is very business-like at times. It's almost as if you're operating a business within the community.
Based on a conversation with a friend who was a doctor, and this was probably 20 years ago, to some extent, I think he could see what was coming 20 or more years ago, that healthcare is a business, that physicians are expected to see a certain number of patients, especially within an insurance system. And, some of them spend less and less time with patients. And sometimes you're really lucky to find one who does spend a lot of time with patients. So it's a crazy situation. That's about, I think, all we could say at this point, which is compounded by the fact that we're in the middle of this pandemic. And you have to be able to listen to people and maybe explain to them why you're doing something. For example, with me, it was never a question of whether I was going to take the vaccine, but was I going to be able to get it, and when was I going to take it? And I agree with you on this, the thing as far as many people saying that there's this fear in the Black community of the Tuskegee experiment and everything. And I would kind of hazard a guess that there are many, many people who have no idea what you're talking about when you say the Tuskegee experiment, unless they've actually sat through a class in African-American history from the 1930s, or lived in Alabama, or been in touch with that level of understanding about what is possible. But they don't have to know about the Tuskegee experiment. That's just simply a set of terms to understand, I think, what all of you have been mentioning, and that is this whole question of how are people treated within a health system? How are they, do they have a sense that they have a chance of living if they go to a hospital, or even if they have a chance of getting into a hospital that would provide adequate care, which I think was what one of you was saying just a minute ago. So you don't have to use a certain set of words like Tuskegee experiment, which in a lot of ways I've come to think that that's just simply a kind of coded language that some people use as a way of explaining why they think African Americans may not be getting the vaccine, when there are so many other reasons that maybe they are not considering, that all three of you have actually brought to us in this panel discussion, that there are other things, other reasons. So, and Dr. Singarella, I would ask, is this something that we are seeing with other communities, with more recent immigrant communities, the same kind of thing? Or is there something else that may be preventing recent immigrant populations, Latinx populations, from participating or from getting vaccines? Are there other considerations that they also bring to the table?
Yeah, certainly. I consider myself privileged because I don't have problems with my documents, and Puerto Ricans are American citizens, but certainly I know other Latinos and Latinas who don't go to receive services because they're scared. They're scared. And we think about Latinos and Latinas, and some of them speak Spanish, some Latinos speak other languages. So the language barrier also is also a big problem in these communities. So we need to keep researching and approaching these communities and learning new strategies to support them. So I want to thank you. Thanks everybody for this opportunity. This has been a great experience for me, and I hope to keep researching, and you will know about our research, our community health needs assessment, and we hope to approach other groups. Thank you.
I wanted to, when Commissioner Sawyer, when she mentioned the essential workers, it was interesting. People kept saying, you got your vaccine, you work at the hospital, but there were groups that were not essential. I work in an outpatient area. I wasn't one of the first, or we weren't one of the first departments to get the vaccine, although we're in healthcare. It's interesting that when you mention essential and who defines it, that is that you were right on target, because I work in healthcare. I go there every day. I'm a nurse. It didn't mean anything because I wasn't considered essential in the role of other people who work ER, ICU, CCU, and I don't know if I don't have an idea if it was because of the number of the original vaccines that came in, if they were limited, but I think everyone in healthcare, many were not considered essential workers as defined by whoever states.
I just wanted to jump in. This is a conversation that I hope we continue, because this is something that we're still living through. But we are technically over time now, but I just wanted to thank all three of the panelists. You guys are doing really amazing work, and I hope that you keep going. And I hope that everyone here converse forward to different communities. Like Dr. Ruggiero mentioned in the chat, this is an issue of about Latinos also being seen, hey, as being more tolerant of pain than non-Hispanic whites. And so this is a level of this is a problem that's not just a black and white issue, absolutely, like Commissioner Sawyer pointed out. But you can, I do strongly recommend that people work with Dr. Singarella's team on the community health needs assessment. And there's also data that people are putting in the chat from the CDC, tracking vaccinations. The library did put together a very comprehensive, and it's growing, the data that they're working with on with health sciences. So I know that this is just the beginning of a conversation, and I hope that we can have another panel like this in the future. There were a number of people I wanted to try to get. There's like 15 people in Memphis that we also need to hear from, in addition to our really esteemed colleagues from tonight. But I want to thank everyone, and hopefully we will get through this in a way that will make Memphis stronger and make it less racist. And that's going to take a long time, but hopefully this is moving people in the right direction. So yeah, let's all thank our panelists. If you want to unmute and give them some my kid's teacher says, give
Thank
them
you.
some shine. Yeah. So